Okay, hello, my name is Aisha, and I'm one of the doctors that's part of the Prescribing and Surgery series. Today's session will be our Q&A session, so our final session. But before we start the session, we've got a quick talk by Daniel, who's from the BMA.
Thanks, Aisha. So, yeah, just very quickly from me, it was just going to be a bit of an update about what's going on, but you've probably been getting emails anyway. Yeah, I'm sure everyone watching now and on repeat is a member anyway, but if you wanted to take advantage of a little exclusive for Mind the Bleep, you can get a month free if you use that QR code that's on the screen. So I'm sure everyone knows what the BMA is, what it does. The way I like to look at it is threefold: individual, local, and national. So on an individual sense, it's sort of like things like the contract checker, so helping you with any sort of personal problems that are unique just to you. So all that sort of things. Local is more sort of your group of F2s, for example, and you're having sort of a similar issue with your rotors. We have people that are on the ground, every trust who can sort of come in and sort that out. And then obviously national, what's going on in terms of strikes and whatnot at the moment. This is over a month ago now, but just a recap of the next mandate that we've got that runs until 19th of September. So the turnout was slightly less, 61%. I think before it was about 71. But yeah, the strike action was still massively high, 97.97, and obviously ASOS, which is something that we introduced for this time round, also got a big yes as well. So action short of striking. This is sort of where we are, despite the government constantly telling us that that's it, that's the final offer. So things are working despite it feeling like they're not. So we just got to keep going basically. A little update. There's obviously no new dates for junior strikes as the talks continue. The consultants agreed their deal last month, so that's coming into effect now. They'll get back paid to March, and then there was an offer to the SAS doctors, which was rejected, and there's no plans for those guys to strike yet. They've obviously got their mandate and haven't actually striked yet, but they're also having talks continue. There's a bit of a lengthy email that I've condensed from last week. Sadly, I don't have any inside information. I sort of get told what everyone else gets told at the same time. But essentially, it sounds like there's good progress with the government, and it sounds quite positive. So I'm waiting, just like you, for an announcement that should be this week. The email went out last week saying next week we'll have some news on an agreement. So I'm waiting to hear that with you guys as well. But it does feel like a different phase, like they said. I can't remember time since 2022, since this began, that such a period has gone without any strikes. So it must be good. What's happening? I would hope so. But obviously, if that changes, if the government are sort of stalling as they did before, let's be honest, then we will call for industrial action again. So sort of touching back on the individual support side of things, these are sort of some of the questions that we get. So just think of BMA as your first port of call, not just for obviously things with the strikes, but also just your day-to-day things around leave, anything non-clinical really. Sometimes we get confused with MDU, but MDU and MPS, the indemnity, they deal with sort of the more clinical side of things, whereas we're fully non-clinical. Contract checker, biggest thing that we'll start reminding everybody about soon with the upcoming inductions in July and August. 25% of the contracts we checked last year, that was mainly around July, August inductions, were wrong. So just get into the mode if you're not already of just sending it in to us, and we'll check it before you sign it. If you sign it and we check it, it's fine. You shouldn't have signed something that was wrong, so it's not the end of the world, but hopefully you remember to send it to us first. You've got obviously full access to lots of other tools as part of a BMA member. So BMA library, full access to that. Clinical Key as well, which is a point of care tool. We run a series of webinars as well that are available to watch live and obviously on demand as well. And you've got full access to BMJ Learning, and you'll be getting a copy of the BMJ through the post, but you can also turn that off. I get those through the post, and they can be a lot. But just know that you can turn those off if you would like to. That's it from me. I'll hand you back to Aisha and let you go on with the session.
Thank you, Daniel. So I'm just going to present the slides now. Okay. So this is our final session in our prescribing and surgery series. So it's our Q&A session. And just to introduce myself, I'm Aisha Musa, and I'm one of the prescribing and surgery co-leads. So just a disclaimer, the prescribing and surgery series has been created by junior doctors entirely on a voluntary basis, and kind of everything we discuss is accurate to the best of our knowledge, and neither the tutors nor mind the bleed take responsibility for any unintentional inaccuracies. And this is just to show you that is our final session in our prescribing and surgery series. So thank you all for joining. So last week I sent out a survey asking what topics you'd like to be covered. And as you can see, there's a variety of topics and quite a lot of people wanted a recap session. There was one person that asked us to cover medical emergencies. And as mentioned last week, our colleagues in Mind the Bleep are hopefully in the next few months going to deliver a Mind the Bleep session on prescribing in medicine. So our 10-part series is solely covering prescribing in surgery. So let's start with our first case. So our first case will be covering VTE prophylaxis and analgesia, which was our first session of this series. So 64-year-old female presents with inability to weight bear and with a shortened and externally rotated right leg. She is admitted to trauma and orthopedics and undergoes surgery for her neck and femur fracture. In terms of her past medical histories, she's got osteoporosis, she's got no known drug allergies, she weighs 98 kg and her creatinine clearance is 40 milliliters per minute. She'll stay in hospital for a few days post-operatively. So the question is, what VTE prophylaxis should she be prescribed on a 24-hour regime whilst in hospital? So I'm just going to start the poll. Okay, so the most popular option so far is A, enoxaparin, 40 milligrams once daily. Any other answers? Give it a few more seconds. Okay, so it's still the most popular option. And yes, the correct answer is enoxaparin 40 milligrams once daily. So I'll just go to the next slide to explain it. So this is just showing that for prophylaxis of DVT in surgical patients, you would give 40 milligrams every 24 hours. And you can give a low molecular, so you'd give low molecular weight heparin, and enoxaparin is just an example. Okay, and this slide is showing you that in clinical practice, you need to take into account a patient's weight and renal function. So in this case, his weight is 99 kg and his creatinine clearance is 40 milliliters per minute. So in clinical practice, you would also prescribe 40 milligrams once daily. So make sure to, when you start prescribing, you use your local trust guidelines. I hope that makes sense. Okay, any questions for this case? Okay, we'll move on to our second case then. Before we move on to our second case, I just want to show you that in terms of duration, NICE says for fragility fractures, you'd offer VTE prophylaxis for a month. Okay, so this is our second case. And this will be covering analgesia. So during her hospital stay, she's prescribed 15 milligrams morphine sulfate modified release BD and PRN morphine sulfate 5 milligrams for her perioperative pain. She's also been prescribed PRN laxatives and anti-sickness medication. You were asked to review after the morning ward round, and she reports developing widespread and worsening pain, hyperalgesia, and allodynia. So just to let you know, hyperalgesia is increased sensitivity to feeling pain, whereas allodynia is pain due to stimulus that doesn't usually cause pain. So, for example, pain from light touch. So the question is, how will you manage her pain? So I'll just start polling. Okay, just give you a few more seconds to respond. Okay. Give you a few more seconds. Okay, the response is fine. Okay, so the correct answer is E. So E is to seek specialist advice and reduce the dose by 30 to 50%. So obviously the options were quite similar to each other. So on the next slide, I'll explain why this is the correct answer. So this is showing you, so the patient has opioid-induced hyperalgesia. So that tends to present with widespread worsening pain, hyperalgesia, allodynia, and myoclonus, which is sudden involuntary muscle twitching. So the guidelines are that you should seek specialist advice and also consider reducing the dose by 30 to 50%. But you can also consider opioid switch using NSAIDs and/or adjuvants. I hope that makes sense. Was there any questions for the previous scenario? Okay then. So we're going to move on to case 2. So this is covering fluids and electrolyte imbalances, which was our one of our sessions as part of the series. So a 12-year-old boy is admitted to the pediatrics ward and is being treated for acute exacerbation of asthma. So in terms of past medical history, he's got asthma, for which he takes a salbutamol inhaler. He has no known drug allergies. He weighs 40 kg. And on examination, his respiratory rate is 12, his sats are 99% on room air, his temperature is 36.5, and his blood pressure is 130 over 80, heart rate 80, heart sounds 1 and 2 present. He's got a wheeze, but it's improving as he's being treated for his asthma. So in terms of his investigations, they are all within normal range. So the question is, calculate the 24-hour maintenance fluid volume requirement for this patient. And I'll release the question into the poll. So please do answer it. Give you a few more seconds to respond. If you don't use the poll, you could just put the answer into the chat as well. Okay, so we've got one response for B, 1800. Any other responses? Okay, give you a few more seconds. Okay, so far 1800. So 1,800 milliliters is the most popular. So the answer is actually C, which is so 1,900 milliliters over 24 hours. But I'll explain it in the next slide. So when calculating fluid requirements for children over 1 month, what we'd use this holiday Sagar formula, and so I'll just show you the workout over the next slide. So essentially, for the first 10 kg, you would do 10 kg times 100 milliliters, which is 1,000 milliliters. Then the next 10 kg, you would do 10 kg times 50 milliliters, which is 500 milliliters. And for the remaining weight, which in this case is 20 kg, you do 20 kg times 20 milliliters, which is 400 milliliters. So the total fluid maintenance requirement for this child is 1,900 milliliters over a 24-hour period. Does that make sense? Are there any questions? Okay, so we can move on to the next case then. So this is also on fluids and electrolyte imbalances. So a 39-year-old man is being treated in the trauma and orthopedics department for major trauma. He's otherwise fit and well. He has no known past medical conditions. He's not currently on any medications, and he has no known drug allergies. During admission, he suddenly develops chest pain, and an ECG is conducted, which shows tall tinted T waves and widened P waves. So on examination, his rest rate is 12. His sats are 99% of room air. His temperature is 36.5, and his blood pressure is 140/70. Heart rate is 100. Heart sounds 102 present with no added heart sounds, and his chest is clear. So in terms of his investigations, they're all normal except his potassium, which is 6.6. So he's very raised. So he's been given calcium gluconate 10% IV, 30 milliliters for hyperkalemia already. So the question is, what IV infusion should he be prescribed to shift potassium into the cells? So I'm just going to start the poll. Give you a few seconds to answer. Any suggestions? You can write in the chat as well. Okay, so the answer is E, so insulin glucose IV infusion. The reason why it's not A is because calcium chloride has the same role as calcium gluconate in that it protects the heart, and he's already been given calcium gluconate. It's not B or C because glucose 10% IV, 150 to 200 milliliters, and glucose 20% IV, 75 to 100 milliliters. Either or are used in hyperglycemia. And it's not D because D is used in severe hypercalcemia. So the correct answer is E. So this is just showing you some guidelines which I don't know if you can make it out, but essentially it says you would give insulin glucose IV infusion. So please use your local policy in terms of how much of insulin and glucose to use. For example, in my local policy, it says to give 10 units soluble insulin in 50 milliliters, 50% glucose over 15 to 30 minutes. So it will differ depending on your local trust. So always make sure to use your local trust guidelines. Okay, so any questions for the previous case? Okay, so we're going to move on to case 4, and this will be covering antibiotics and blood transfusions. So a 30-year-old female presents to A&E with dysuria, painful periods, and green vaginal discharge. She's not pregnant. She's referred to the OBGYN team. They review her and note on vaginal examination she's got inflamed cervix and green vaginal discharge is also noted. They have taken vaginal swabs and her bloods, which show that her inflammatory markers are raised. They ask you to start her on antibiotics for pelvic inflammatory disease. So which antibiotics would you prescribe for her pelvic inflammatory disease? So I'm just going to start the poll. I'll give you a few seconds to answer this question. Okay, so far the most popular option is C, doxycycline and metronidazole. Any other suggestions? Okay, so far C is the most popular. So the answer is A. So A is doxycycline 100 milligrams BD for 14 days, metronidazole 400 milligrams BD for 14 days, and a one-off dose of ceftriaxone 1 gram IM. So the key thing to note about this scenario is that she's not pregnant because doxycycline can't be given to pregnant women as per the BNF. They mentioned that in the first trimester animal studies, it affects skeletal development, and in the second and third trimester, it may cause discoloration of the child's teeth, and at large doses, it can also cause maternal hepatotoxicity. So B is not correct because B is used for hepatic encephalopathy, and it's not C because doxycycline and metronidazole are used in patients with animal bites when the patient is pen allergic. And it's not D because amoxicillin, clarithromycin, and omeprazole is triple therapy for H. pylori, and it's not vancomycin because it's used for C. difficile infection. Okay. So this is just showing you again the BNF guidelines, showing it's doxycycline, metronidazole, and one-off ceftriaxone for PID. That's for 14 days. I hope that makes sense. Was there any question for the previous case before we move on to case 5? Okay. So case 5, this will be covering antibiotics and blood transfusions. So a 54-year-old man presents to A&E with major GI bleeding. He's been transfused red cells and is being investigated by the gastroenterology team for his GI bleeding. In terms of his past medical history, he's got atrial fibrillation. He's currently taking warfarin and bisoprolol. And he's got no known drug allergies. In the meanwhile, you've been asked to manage his warfarin prescription considering his major bleeding. So the question is, how should you manage his warfarin prescription during his major bleeding? So I'll just release the poll into the chat. Give me a few seconds to answer this question. Any suggestions for this question? You can put it into the chat for your answer as well, or you can use the poll. Guess I'll give it a few more seconds. Okay, so far the most popular option is A, stop warfarin, give vitamin K IV injection, and then give dried prothrombin complex. Okay, and this is the correct answer. So this is just showing the nice guidelines. So when you go into the treatment summary and you go into the oral anticoagulants section, there's a section on hemorrhage. So it says in the case of major bleeding, you would stop warfarin, you would give vitamin K by slow IV injection, and you'd also give dried prothrombin complex, which contains factors 2, 7, 9, and 10. And it also gives you guidelines on what to do in minor bleeding, if there's no bleeding, and depending on INR levels as well. I hope that makes sense. So any questions on the previous case? Okay. So case 6 will be covering prescribing and pre-op. So a 58-year-old female is scheduled for a left knee replacement in 6 weeks. In terms of her past medical history, she's been diagnosed with osteoarthritis, and she takes the HRT. She's got no known drug allergies. So the question is, prior to her surgery, how will you manage her HRT prescription? So I'll release the poll into the chat. give you a few seconds to answer the poll, or you can put your answer in the chat. Any suggestions? Okay, we'll give you a few more seconds. Okay. So the answer is B. So you would stop HRT 4 weeks before surgery. So this is from the BNF, from the treatment summary, from the sex hormones section. So it says for major surgery under general anesthesia, including orthopedic surgery, because of the risk of VTE, you would need to stop HRT 4 to 6 weeks prior to surgery, and you'd only restart it after full mobilization. Okay. So any questions for the previous case? Okay, so we're going to move on to case 7, and this will be covering diabetes medication. So a 61-year-old female is scheduled for an elective inguinal hernia repair tomorrow morning. So she's diagnosed with type 2 diabetes, for which she takes linagliptin 5 milligrams once daily, and she's got no known drug allergies. So the question is, how will you manage her linagliptin prescription on the morning of her surgery? Will you omit it the day before surgery? Will you reduce the dose by 20%? Will you omit it on the morning of the surgery? Will you continue as normal? Or will you omit on the morning of the surgery and the following 24 hours after? So I'm just going to release the poll into the chat. So far, the most popular option is to continue as normal. Any other suggestions? Okay, so the most popular option is to continue as normal, and that is the correct option. So this is just guidelines from the Centre for Perioperative Care, and it shows that in the case of linagliptin and other DPP-4 inhibitors, you would take it as normal. So you take it as normal throughout the whole perioperative period. The day prior to admission, if the patient has an AM surgery, if the patient has a PM surgery, it doesn't matter, you would take it as normal throughout the whole perioperative period. I hope that makes sense. Any questions for the previous case? Okay, so we'll move on to case 8, which will be covering surgical emergencies, part 1. So a 50-year-old male presents to A&E with inability to urinate for the past few hours, and he's in a lot of pain. He also has urinary frequency and urgency. So he has urinary frequency and urgency in the past. He's been given painkillers. In terms of his abdominal examination, he's got suprapubic pain and palpable distended bladder. A DRE examination has been done, which shows enlarged prostate, and the bladder scan shows that there's 800 milliliters of urine in his bladder. You suspect he has acute retention secondary to BPH, which is benign prostatic hyperplasia. So the question is, how will you manage his acute retention secondary to benign prostatic hyperplasia? So I'm just going to release the poll into the chat. I'll give you a few seconds to respond. So far, the most popular option is A, catheterized and prescribed tamsulosin, 400 micrograms per oral once daily. Any other suggestions? Okay, so far the most popular option is option A, which is the correct answer. So A is correct. B it's not correct. So you can't wait. You need to treat his acute retention, and it's not C because you wouldn't just catheterize. You'd also need to give the tamsulosin because it's secondary to BPH. It's not D because phenoxymethylpenicillin is used for acute sore throat, and it's not flucloxacillin because it's used for soft tissue infections like cellulitis. You need to check your local trust guidelines as to when to catheterize patients. So it tends to be when the blood scan shows a volume of 300 to 400 milliliters plus, but some consultants may consider catheterizing at a lower volume if the patient's in a lot of pain, if they suspect urinary retention, and it depends on like a case-by-case basis of what's the cause, past medical history, etc. So please do make sure to use your local trust guidelines. So this is just showing you nice guidelines saying that acute urinary retention is a medical emergency, and you would catheterize, and also before the catheter is removed, you'd give an alpha adrenoreceptor blocker, example of which is tamsulosin, and the dose for tamsulosin would be 400 micrograms once daily. So make sure to give micrograms, not milligrams. Yeah. Any questions for the previous case? Okay, so case 9 is covering surgical emergencies part 2. So a 52-year-old man is admitted to A&E with severe bone pain in his fibula. He reports having a fever and recently having surgery for a fibular fracture. In terms of past medical history, he's got type 2 diabetes, for which he takes metformin 500 milligrams BD, and he's got no known drug allergies. He's referred to orthopedics who have conducted an X-ray, taken tissue MCNS, as in microscopy and culture and sensitivity, and have started him on flucloxacillin 2 grams QDS IV for osteomyelitis. The nurse reports that he appears unwell and you ask to see him. So his rest rate is 16, which is high. His stats are 98% on room air. His temperature is 38, he's got a fever. His blood pressure is 100/70, so he's hypertensive. And his heart rate is 136 beats per minute, so he's tachycardic. His chest is clear, his urine dip is clear, and his cap refill is 3 seconds. So the question is, how would you manage him currently? I'll just release the poll into the chat. Give you a few seconds to answer the question. So far, the most popular option is C, which is take bloods, including blood cultures and lactate, catheterize, and give IV fluids and IV antibiotics. Any other suggestions? Does anyone have any other suggestions? You can put it into the chat as well. Okay, so far C is the most popular option, which is correct. So this patient has sepsis secondary to osteomyelitis. So it's not A or B because he doesn't require oxygen because he's maintaining his saturation on room air. And it's not D or E because it's not D or E, they're not complete answers. It's C because it includes everything. So the sepsis 6, except the oxygen, which he doesn't require. So this is just showing you the sepsis action tool from the Sepsis Trust. So essentially shows you kind of amber flag criteria, red flag criteria, and it lets you know to start the sepsis 6 pathway. So in terms of sepsis 6, it's give 3, take 3. So you would take lactate and give oxygen if required. You would take blood culture and give antibiotics. You would take urine output, or you'd catheterize by catheterizing them, and you would give IV fluids. So I hope that makes sense. Any questions for the previous case? Okay, so we're going to move on to case 10, and so this covers general surgery, colorectal, and neurology. So we had a session on this, and this case will cover neurology. So a 33-year-old pregnant woman is admitted to hospital and managed for poorly controlled hypothyroidism. She has a catheter inserted during her admission for urinary retention. You asked to see her, and she reports having dysuria and a foul-smelling urine. She's not severely unwell, and she's able to tolerate oral medication. So in terms of her past medical history, she's got hypothyroidism, for which she takes levothyroxine, and she's got no known drug allergies. Her catheter is changed, and the consultant wants you to prescribe her antibiotics. So the question is, which antibiotics would you prescribe for her catheter-associated UTI? So I'll just release the poll into the chat. I'll give you a few seconds to answer this question. Okay, so far the most popular option is B, which is cephalexin, 500 milligrams 2 to 3 times a day for 7 to 10 days. Any other suggestions? You can put your answer in the chat as well. Okay, so far B is the most popular answer, which is correct. So cephalexin, 500 milligrams 2 to 3 times a day for 7 to 10 days. So the reason why it's not pivmecillin NAB, hydrochloride 400 milligrams, initial dose then 200 milligrams, is because this is second line for UTI in non-pregnant women, and you'd only use it if there's no improvement after at least 48 hours or if the first line option is not suitable. And the reason why it's not C, nitrofurantoin 50 milligrams QDS, is because it's not used in catheter-associated UTI in pregnant women, but you can use it in catheter-associated UTI in non-pregnant women or men. And it's not D because fosfomycin 3 grams per oral single dose is second line for UTI in non-pregnant women. Again, if there's no improvement after at least 48 hours or if the first line is not suitable. And the reason why it's not E, Flaxin 200 milligrams BD, is because this is used in epididymolysis. And this is just showing you again in catheter-associated UTI, you'd use cephalexin, and the dose for adults would be 500 milligrams 2 to 3 times a day for 7 to 10 days. It can be increased if necessary to 1.5 grams 3 to 4 times a day. Increased doses are used in severe infections. Hope that makes sense. So any questions for the previous case? Okay, so this is our last case for today, and this is covering the content for last week's session. So last week's session was on TNO, ENT, and pediatrics. So this will be covering ENT and pediatrics. And so the case is a 3-year-old boy presents to A&E with right ear pain and a fever. His mum reports that he's been feeling generally unwell. He's not been diagnosed with any medical condition. He's not currently taking any medications, and he's got no known drug allergies. He weighs 12 kg. So in terms of the otoscopy findings, he's got a bulging red inflamed tympanic membrane, and he's got no perforation. He's diagnosed with otitis media, and you're asked to start him on antibiotics. So the question is, which antibiotics will you prescribe for his otitis media? And I'll release the last poll of the day into the chat. And I'll give you a few seconds to answer. Okay, so far our most popular option is B, which is co-amoxiclav 250/125 milligrams per oral TDS for 5 to 7 days. Any other options? Any other suggestions for this question? You can also put your answer in the chat as well. Okay, so the most popular answer is B, co-amoxiclav 250/125 milligrams per oral TDS for 5 to 7 days. The correct answer is A, which is amoxicillin 250 milligrams TDS for 5 to 7 days. So the reason why it's A is because A is the first line in otitis media if the patient's not penicillin allergic. The reason why it's not B is because co-amoxiclav is used as second line for otitis media in children who are not penicillin allergic. So you would only use this if they have worsening symptoms despite being on 2 to 3 days of antibacterial treatment. Whereas in his case, we're just starting him on the treatment now. It's not C because clarithromycin is used as first line for otitis media in children who are penicillin allergic. And you need to dose it according to the age and weight. So because he's 3 years old and he weighs 12 kg, you would give him a dose of 125 milligrams BD for 5 to 7 days. And it's not D because flucloxacillin 125 to 250 milligrams QDS is used for otitis externa if there is no penicillin allergy. And it's not E because ceftriaxone 1.2 grams per oral once daily is used for meningitis. And this is the dose you would give to him because he weighs up to 50 kg and he's 1 month to 11 years old. I hope that makes sense. So this is just showing you that in the case of otitis media, first line in a patient, in a child that's not penicillin allergic is amoxicillin, and because he's 3 years old, you would give a dose of 250 milligrams 3 times a day for 5 to 7 days, and this would be by mouth. Okay, I hope that makes sense. Is there any questions for this case? Okay, so these are my references. And this is just a feedback form that I'll be releasing into the chat. And this will just help us know what we've done well, how we can improve, how beneficial you found this talk, and it will also allow you to have a certificate for your attendance. So as I mentioned, this is our final lecture in our 10-part prescribing and surgery series as part of the Mind the Bleep organisation. So thank you very much for attending our sessions. I hope you found them useful. If you didn't manage to attend any of our sessions, or if you'd like to perhaps go through the lectures again, go through the slides, we would have already uploaded the PowerPoint slides and the recordings on the Medal platform. I'll also be uploading these slides and the recording of today's session as well. So hopefully you can go through it at your own pace and you can revisit it as many times as you want. As I mentioned earlier, hopefully our colleagues as part of the Mind the Bleep organisation over the next couple months will also be creating a similar series where we'll go through prescribing in medicine. So thank you very much for attending today's session. I hope you found it useful. And thank you again from me, from Dr. Hermione Gemma and Dr. Sonia Petrosian as part of the prescribing team. Thank you.